Thank you. Okay, so as Dr. Ariel mentioned, I'm professor at the University of Manchester, Manchester Royal Infirmary, and I'm also a visiting professor in Romania and Moldavia. I've been working in the diabetic foot now for 2 decades, and I run the surgical trials unit in Manchester, which we name Maverick, which is the Manchester Academic Vascular Research and Innovation Centre. We are the Northwest of England Referral Centre for diabetic foot under the auspice of Professor Andrew Bolton, and we see 30 to 40 patients on a weekly basis, some rotating patients, all with diabetic foot issues. The paper I'm going to present today is a paper that both I, Nicholas Tentalaris, and Edward Jude published a few years ago in the British Medical Journal. And this was a diagnosis, a differential diagnosis of Charcot neuroosteoarthropathy. I'm going to present some new data, and this data is based on imaging. And can we predict whether a Charcot foot will occur, will not occur, and to what degree of deformity will it occur to if left untreated? Next slide, please. So we looked at 3 specific joints within the midfoot. We excluded the ankle and the digital region. We looked at the Lisfranc joint. We looked at the navicular cuneiform joint, and we looked at the talonavicular joint. And what we're trying to predict here, can we see any morphological shape occurring before a Charcot neuroosteoarthropathy occurs to such a degree it can be seen radiographically? Next slide. Super. So I think a lot of you will already know this. We know it's an increasingly common destructive disease. We know we get fractures, fragmentation, and collapse. Ultimately, these lead to amputation. And we know that it's a complex biomechanical chain of events to which we know very little about. As you can see on the right-hand side, the central picture, this is one of my patients walking through a visual 3D Vicon system. This is an 8-camera system that picks up the retroreflective markers, and from that, it predicts the joint angles and the joint motion within the foot and the ankle, respectively. Next slide, please. So where we've taken this idea from, we've taken this idea from the computer science department, computer vision. This bone finder imaging map is pretty ubiquitous through maxillofacial surgery and through orthopedic surgery, looking at the morphological changes within what is perceived to be the normal and what is perceived to be abnormal. As I already mentioned, it's a machine learning radiograph. It was developed here at the University of Manchester by 2 of my colleagues, and it extracts shape, texture, and simultaneously converts that into a pictorial image. So i.e., it converts complex shapes into a continuous data set. We can look at any joint within the body. Obviously, from our perspective, we're looking at the foot and the ankle, but it is also used in the hip, knee, and as I mentioned, maxillofacial surgery for when they're doing maxillofacial recognition for the prosthesis or the prosthetic implants. So we've basically taken this machine modeling and we've adapted this to the Charcot foot to predict A, whether a Charcot foot will occur, and B, to what severity. Next slide, please. So the software itself can extract new morphological data that certainly cannot be seen by the eye or any other sort of visual recognition, and it can turn shape and texture into continuous data. So if you put in a series of numbers or a series of figures, then from that series of numbers or series of figures, from that data set, what we class as a data set, it will give you that pictorial image of the dots that you can see around the articulating surfaces. Next slide, please. Keep going. And keep going. Fabulous. So what we can see is if you look at this video, the small video on the right, and you can see that collapse, that is basically what the data is taken within the visual 3D, within the Vicon system, real time. So that's actually a patient walking, and then that's where the actual foot, you get those deforming forces. Next slide. As mentioned, we're looking at shape and texture, features in normal appearances, and certainly as predictors of subsequent Charcot. So this is a young chap who's doing this at the moment. He's a PhD student in the Department of Engineering here at the University of Manchester. And this machine model, this bone finding model, makes up a large portion of his doctoral studies. Next slide, please. So I think this is pretty obvious. We know what a stage 0 radiograph looks like. It appears normal. But what we see under the bone finder, from what we've already extrapolated, we can see that that's simply not the case. And what we're looking for is what we cannot see with the eye itself, what we can actually see with the machine. So, as I say, what if you could find a diagnostic feature, i.e. improved detection, and understand the morphological risk and the risk factors? Because we all know that Charcot foot itself is a devastating complication of diabetes. Next slide, please. And next. Fabulous. So stage 0, as you can see from Dottie, it's we have a pretty equal distribution from what we see in the hind foot, forefoot, and midfoot of the articulating surface. So we've got, for the stage 0, we've got an equal pattern across that stage. Next slide, please. And what we can see from this candidate, the shape and component is 3, which you can see the BC and BC again, and that is obviously respected to the classification of the Charcot, so stage 0 to stage 1. So he's picking up already those minor detections. If you look at the red box, that is what we call the lazy S shape. And if you look at the B box, that's what we call the broken lazy S. So we know already from that that we're getting some destruction within the midfoot itself. We know what the odds ratio are, 5.7, and obviously I don't have to tell you guys online what an odds ratio and a p-value indicates, but at the moment, obviously 0.002. And obviously we've got the increasing odds and the decreasing odds of the actual deformity itself. Next slide, please. So what do we need? At the moment, we have 100 cases from the data that we've extrapolated from plain radiographs. So really, in short, we need more radiographs to confirm that what we are seeing in the very early stage of Charcot foot and longevity actually does go into a Charcot itself. Next slide, please. So what are our next steps? From what we see, that's expanding our data set, as I've already mentioned, adding new models and views. So maybe looking at the hindfoot, i.e. the ankle, and the digital region. More on the segmental analysis, the morphology versus the alignment, and the collapsing patterns. Does the shape of the foot predict ulceration? We know if we get a midfoot collapse, then we get high propensity for ulceration under the midfoot. But is it actually a predictor from where we see this bone sort of remodeling? Next slide, please. Next slide again. Fabulous. So this is the bone finder itself. If anybody wants to have a look at this, this is where you can find it online. As previously mentioned, it's quite ubiquitous through maxillofacial surgery, mainly for prosthesis, and they can get for want of a better word, an identical match. Now, the presentation for the actual talk was the multidisciplinary team. So what I've done in this presentation, the multidisciplinary team must also be the engineering department, and bringing as many specialities in as what we can use. I'm sure many people who know me on a personal level, I started life off as an engineer and worked as an engineer with a degree in engineering, and then swapped over a little later in life to do what I do today. But the engineering department, the computer science department with the engineering department have excellent prognostic indicators for shape and morphological changes using software systems like I presented today as predictors ultimately for a Charcot neuroosteoarthropathy. Thank you very much for listening. It's a pleasure seeing you all as always. I hope that you took something away from the actual presentation itself, but I really do feel that working within other specialities or alongside other specialities, we can get this cross-fertilization of skills ultimately for patient and patient benefit. Thank you very much.